Hi, my name is Liisa Galea, and thank you so much for the opportunity to pre-record my talk. I wish I could be there with you, but unfortunately, COVID had other plans for me. I'm being a little provocative with my title of my talk, but I do really feel passionately that understanding sex and sex-related factors will really matter for understanding risk and resilience to dementia. And I think it's really obvious that there are a number of sex and gender differences that we can see across the lifespan. You're probably very well aware that human females are more likely to live longer than human males, but you may not be aware that they're also more likely to live with chronic illness. And in fact, a recent World Economic Forum report suggested they human females have 25% more time in chronic poor health than men do. This paper came out looking at the Danish registry showing that females had, on average, a delay of 2 years or more for a variety of different disorders and diseases. So it was over 1,300 different disorders. If you just looked at the delay, the 75% of disorders where females had a greater delay, that was over 980 different disorders, is 3.7 years. And obviously, this has a lot of repercussions for our health. And there are a number of reasons for this delay on both the biological and social side of things. I think one of the primary reasons is that most of our medical knowledge, including the way we diagnose people, is based on males and the experiences of men. So much so that a number of symptoms in females across a wide variety of disorders are called atypical. And you see this atypical label across where you see differences in prevalence, favoring males or females, or there's no evidence of a prevalence difference between males and females. And I think that suggests a systemic bias. Now, we know that there are a number of sex influences in the brain in terms of gray matter volume, in terms of white matter volume. People have tried to explain these away by body size and brain size, but there are some really fantastic articles out there showing that this is not the only thing that matters. Now, these may or may not contribute to the fact that we see sex differences in prevalence. Of many different disorders, as we talked about already. I'm actually more interested in the fact that we also see sex differences in the manifestation of disorders, including Alzheimer's disease. And that's what I'll talk a little bit about. If you see a sex difference, that should automatically cue you to think that sex chromosomes, sex hormones, or some combination of the both could be at play. And our funding agencies have been mandating incorporation, and we can see, surveying the literature, and this is something we did a couple of years ago, that there's been a big uptake of studies that have looked at or are including both males and females. Very few are looking at gender, unfortunately. But unfortunately, we also see very few are incorporating what we're calling an optimal design, which just meant, did they disclose their sample size? Another is that they're not analyzing with sex as a meaningful variable, so only 5%. And I have to tell you, there are more studies coming out that that are going to show that this hasn't, nothing has changed. It's still a very low level. And I really do think that there's a resistance to setting sex as a factor. I wish I had more time. I don't have enough time, but I'll just touch upon these last three things here in this talk. And one is that I think a lot of people don't realize that there are many kinds of sex differences, and people are searching for sexual dimorphism, which is very rare. And in fact, there are things that I'm going to call hidden sex differences, so-called mechanistic and latent differences. And that's when you might not see a sex difference in a trait that you're interested in, but that doesn't mean that the underlying neural or molecular mechanisms underlying that trait might not be completely different. Or that you might not see a difference, but something comes along like age or genotype that drives a difference either in the expression of that trait or in the neural and molecular mechanisms underlying that trait. And I'll give you some examples of these. One of the last things I want to say is that, setting sex or gender is only one step. We also need to understand that female-specific experiences can drive health outcomes and disease risk, including dementia, and are even more rarely studied than sex differences or gender differences. So today, in the next few minutes, I'm going to talk to you about the dangers of the male standard using diagnosis as a factor. I'm going to give you some examples of a latent sex difference using people at risk for Alzheimer's disease. And we'll touch a little bit upon mechanistic sex differences. And I'll finish off by talking about why sex-specific studies are also important, and I'm going to use pregnancy history. So we know that there are a number of modifiable and non-modifiable risk factors for late onset sporadic Alzheimer's disease, and I've put some common ones up here. And sex plays a role in every single one of these factors. Again, I wish I could talk about all of them, but I'm going to talk more about the interaction between these two. So 50 to 60% of people with late onset sporadic Alzheimer's disease will have one or two of these ApoE4 alleles. And if you're female at risk for Alzheimer's disease, female with one of these two alleles, you're also at greater risk. Now, another population that's at great risk for Alzheimer's disease is people that are diagnosed with amnestic mild cognitive impairment. About 50% of these will transition to Alzheimer's disease. I think a really fantastic group to study if you're thinking about risk and resilience. And what I'm going to call the sex paradox is that there are more men that are diagnosed with amnestic MCI and more females that are women that are diagnosed with Alzheimer's disease. So why is this? Why would this be? And why not use this information to harness the power of sex differences and how can we can understand? And before I go there, I just want to talk about the dangers of the male standard. And my GIF isn't working, but many of you will know where this is from. And that is that we see a number of, I think that we could have a number of issues arising even from diagnosing people if we're not using sex-informed information to diagnose accurately. So what do I mean by that? Here we see that human females are scoring higher on global cognition, executive function, verbal memory. And if we're not using sex-specific norms to diagnose people that are having cognitive impairment, we're going to be missing some females. And in fact, that's exactly what Erin Senderman showed using retrospective data, that if she used sex-specific norms to diagnose people with amnestic MCI, she could improve diagnostic accuracy by 20%. She found 10% more females at risk and 10% fewer males at risk. And I think we really have to think about this both on a personal level for the individual, but also on a level of trying to understand what biomarkers or social determinants of health might be driving risk or resilience. If we don't have the right population to begin with in terms of our diagnosis, that's going to impede our discovery. Now, we and other people have been looking at markers, phospholipid tau or tau and amyloid beta to see if we see differences between males and females. This is using the ADNI database. We incorporated diagnosis as a factor as well. That didn't come out in the analysis. It was just a sex by ApoE4 genotype interaction. And so here, hopefully what you can see is the females in the lighter blue. If they're a carrier, and this is just one or two alleles, they had disproportionately elevated levels of tau. We also looked at phospholipid tau. That was also the same. This is an example of a latent sex difference. No sex difference in non-ApoE carriers in terms of tau levels, but you see one that's elicited in a certain genotype. Now, Rachel Buckley has seen something very similar. She's looking at kind of normal people. She has other databases out there that she's analyzed as well, and a very recent paper showing very similar findings. And what she sees, again, looking at CSF levels for tau or phospholipid tau, that if females have more amyloid beta, and so this is in this sort of red color here compared to females that don't have a high load, you see a difference in phospholipid tau only in the ApoE carriers and only when you're comparing those with a heavy amyloid beta load to those with a low amyloid beta load. And you don't see the same difference in the males. Again, suggest to me, not again, but suggestive to me of a mechanistic difference between males and females in terms of phospholipid tau. Another example of a latent difference would be that females with amnestic MCI, and this is using the ADNI database again, show greater cognitive decline over time compared to males with amnestic MCI, and you don't see any evidence of a sex difference in the people that have a low risk for Alzheimer's disease, again, suggestive of a latent sex difference. So what I hope I've shown you so far is that sex differences go beyond greater lifetime risk and longevity, and that I think is really important to study these high risk to transition to Alzheimer's disease individuals using that power of sex differences. And unfortunately, I have to tell you, it's very rarely considered in the literature. Now, I'm just going to show you one data slide, as most of my work is done in preclinical models. So we're looking at mice and rodents. And we've been looking, as I said, very interested in this ApoE4 by sex interaction. And so here are rats. These are middle-aged rats. We're looking at neural stem cells in the hippocampus. And these are immature new neurons, so neurogenesis. And these are again middle age. The males are in green here. And what you see is the rats that have had this human knock-in of this ApoE4 allele, they show lower levels of neural stem cells and lower levels of neurogenesis. And this is exactly what we might expect, right? We know they're at greater risk. They're showing a neural phenotype that looks like something we would expect. Now, the females don't show the same pattern. Remember, they're the ones at greater risk. So there's no difference in neural stem cells, and actually there's an increase in neurogenesis. And I'm sure many of you are thinking, well, it's just a crappy model, and this is why I don't want to look at rat data. It may be a crappy model. That is one possible explanation. But another explanation is that it makes sense to us in males because we've had this male standard, because we rely so much on male data, and the females don't make so much sense. The other thing I want to point out is if we combine this data, if I didn't use sexes analysis here, we wouldn't see any differences between these groups. And I think that's kind of important to point out. It also is very possible this is a example of a mechanistic sex difference here, that the mechanisms underlying eventual cognitive impairment may be very different in males versus females. And I was really gratified to read this sentence in a Jessica Caldwell paper looking at human data. And she writes here that these findings suggest that women have a neural reserve at the level of the hippocampus, the same area we were looking at, such that hippocampal integrity is robust to the effects of amyloid beta in preclinical stages in women. Now we're looking at female rats, but we see the same thing, that hippocampal integrity is pretty robust. And in that case, we did see high levels of amyloid beta load in that model. So hopefully, what I've also given you an example of is that there are sex by ApoE4 genotypes in neurogenesis and middle age, suggesting these sex differences and mechanisms of integrity loss with ApoE4. I hope I've also demonstrated that males cannot serve as a default for females. We see too many differences. I study this, happy to answer questions about it. And also that there are hidden sex differences. So even when there might not be one in the first thing you look at or in your main effect, you are going to need to look at interaction effects. And now in the last couple of minutes, I want to talk about female-specific risk factors for late onset sporadic Alzheimer's disease. And we study a number of them, but I'm going to talk about pregnancy history. And in rodents and in humans, we see evidence of more plasticity in middle age with previous pregnancy. So we've seen more synaptic proteins in the hippocampus, more new neurons, and Anne-Marie DeLange has shown using the UK Biobank that there is less evident brain aging in people. It doesn't matter how many childbirths they had. But we also know despite this decrease in brain aging, that there seems to be an increased risk for Alzheimer's disease with parity. But when you look at the literature, and there's more and more papers that are coming out, there's a real hodgepodge. It's really equivocal. And I won't show you any more data from our animal models, but I believe that we can use a healthy cell bias to explain some of this equivocal nature. And I'm borrowing that from Roberta Brinton, such that if you have an ApoE4 allele, if you're at greater risk to develop Alzheimer's disease, a previous pregnancy might be more detrimental to your brain health. But if you don't have that risk, it actually might confer a benefit. And there's actually 2 papers, including one of our own, showing this relationship. So here we know that female-specific factors do influence aging and Alzheimer's risk. We don't know enough about it. Only 3% of studies are looking at female-specific factors. Why does it matter? It matters for precision medicine. The drug lecanemab, as many of you probably know, doesn't work very well in females as it works much better in males, but that's very rarely mentioned. It also doesn't work at all in homozygotes, more in hetero or non-carriers. It also doesn't work in Black individuals or Hispanic individuals, not as well as in white individuals. And that's really important information. I wish it was out there in the common lexicon. The last thing I want to mention, I know I'm over time, is that studying sex is not going to reduce your power. There have been a number of studies now looking at this. I forgot I was going to hide that one. And just want to say, look, you got the power. If you have a reverse effect, you actually increase your power. If you have no difference, you don't change your power at all. So please incorporate sex as a factor. Please join the Women's Health Research Cluster if you want to learn more. And thank you very much for your time.